Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital in London. I'm also the vice chair of the BTOG steering committee.
And I'm Lianne, a respiratory physician at Barts Hospital in London.
This is part of our regular podcast series where we have informal chats with experts in their field and tackle the most important issues that we all face in the diagnosis and treatment of thoracic cancers.
It is important to say that the sponsors of BTOG do not have any role whatsoever in the planning, content or delivery of anything discussed in these podcasts. We would love to hear your questions and comments on things we've discussed in this podcast. Please contact us by emailing us at info@btog.org or tweet us at btog.org.
Please review and like us on the platform where you access your podcast to help us spread the word about BTOG educational events. Today's podcast is about metastatic advanced stage neuroendocrine tumours, and I'm absolutely delighted to welcome my colleague and friend, Dr. Debashis Sarker. Debs, welcome to the BTOG podcast.
Thank you so much, Tom. Pleasure to be here.
First of all, before we kick off, tell us about you. Where do you work and what do you do?
Sure. So I'm a bit of an interloper because I'm an HPB medical oncologist with a specific specialization in neuroendocrine tumors. I'm based at Guy's and King's College Hospital. We have ENETS, which is the European Neuroendocrine Tumor Society of Excellence, Centre of Excellence across Guy's and King's. I'm also a genomics lead at Southeast Genomics Laboratory Hub, and I also do quite a lot of early phase clinical trials as well. So I wear a number of different hats.
A number of expert hats. And of course, we recognize the importance of neuroendocrine tumors for us as thoracic oncology teams, but we welcome all members to our BTOG podcast. So you're very welcome.
Thank you.
Brilliant. And so just to kind of kick us off, it's a big topic, but could you just start by talking to us about the spectrum of neuroendocrine tumours, because it covers quite a broad, different group of tumours with several different subtypes. And perhaps if you could enlighten us all just about those different subtypes and how they differ.
Sure. So as you say, neuroendocrine tumours of the lung are a spectrum. So on one end of the spectrum, you have the well-differentiated neuroendocrine tumours, which are the typical and atypical lung carcinoids. And on the other end of the spectrum, you have the more poorly differentiated neuroendocrine carcinomas, which are the large cell neuroendocrine carcinoma and small cell. So typical and atypical carcinoids are what I treat, and clearly there are differences in terms of who looks after these patients from an oncological perspective. Many are looked after by lung oncologists such as Tom, and many are looked after by neuroendocrine specific specialists like myself. But yeah, as you say, they're a spectrum. The well-differentiated neuroendocrine tumors, as I said, that I look after, the two main types, as I said, are the typical and atypical carcinoids. The main way that they are differentiated is histopathologically. So the key things that your lung or neuroendocrine specialist pathologist should be able to tell you is the number of mitoses per 10 high power fields, and also whether there's the presence of any necrosis. So for typical carcinoids, the diagnosis is made based on less than 2 mitoses per 10 high power fields. For an atypical carcinoid, it's between 2 to 10, or the presence of focal necrosis. On the other end of the spectrum, as I said, neuroendocrine carcinomas such as large cell and small cell are very morphologically very different and obviously associated with much higher mitotic rate. The other key thing that is not specifically mandated when by a pathologist, for example, in the WHO classification, of which there was a further iteration last year, is the use of KRAS67 as a proliferation index. So we use this routinely for gastrointestinal neuroendocrine tumors, but it's not mandated for lung, but increasingly we are using it just because of the kind of diagnostic and prognostic value associated with this. And certainly both the US and the European neuroendocrine tumor societies recommend that KRAS67 proliferation index is done.
And what's the cutoff there? I'm used to small cells being 90, 100%. What numbers are you looking at for carcinoids and atypical carcinoids?
Yeah, so I think this is part of the reason why it hasn't been incorporated, because, say, for example, for GI neuroendocrine tumors, it's very well established that grade 1 is less than 2% Ki67, grade 2 is 2 to 20%, and anything over 20% is grade 3. So that distinction and those gradings that we have for GI neuroendocrine tumors, that hasn't really, we haven't got the same level of validation in terms of those cutoffs. So, obviously we may in time have that done to a much higher degree that it is actually incorporated within the kind of classification systems. I think the other thing to say is probably that genomically they're very distinct. So typical and atypical carcinoids are associated with genes which are actually quite similar to the GI neuroendocrine tumors, such as genes such as MEN1, chromatin remodeling genes, whereas obviously we know large cell and small cell is associated with loss of TP53.
So do you see them as, I never realized that. So do you see them actually as, we see them as, talked about a spectrum. Do you not see them as a spectrum? Do you actually see that they're two distinct pathological processes?
I think I think it's important to look at them as a spectrum. All neuroendocrine, if we take all of neuroendocrine cancer as a whole, then, we always regard it as a spectrum. And within that spectrum, there are clear entities, and, differentiation is often the biggest way that we can kind of divide these up, broadly speaking, into well and poorly differentiated. And as I said, clearly you can see distinct clinical, pathological, and genomic differences between well differentiated lung tumors versus poorly differentiated ones. Having said all of that, often there are many cases that don't fit into these kind of clear criteria and into these kind of clear categories. So, for example, there is this category of large cell neuroendocrine carcinoma, but with more morphologic features of a carcinoid tumor, and in the net world we've kind of called these supracarcinoids. So there are these kind of overlap entities that I think that concept of a spectrum becomes quite important. Also important to say that from the typical carcinoids generally are much more common than the atypical carcinoids. So certainly if you in terms of a surgical practice, probably you'll see 8 to 10 times more typical carcinoids versus atypical carcinoids. Whereas when it comes to patients with more advanced disease, metastatic disease, it's more kind of similar in terms of numbers. So, yeah.
Is there a range of atypical carcinoids? Do you look at them in your expert MDT and say, this is a really nasty one? This has a higher rate of atypia, a higher Ki67, for example, or are they all much homogenous?
No, I think you've hit the nail on the head there. And that's precisely where Ki67 becomes really helpful, because, if you're going up to, with an atypical, morphologically, it might be an atypical carcinoid, but with a very high Ki67, then that clearly has got a more aggressive phenotype. And that's likely then to be represented in terms of the clinical picture, the functional imaging picture, and then obviously how you think about treating that patient.
Okay, I'm going to ask about functional and non-functional nets. I find this unbelievably confusing. I'm a simple man. When should we check? How should we check? I remember urinary 5-HIAAs. I remember blood tests. I tend to forget them, and then when I come to clinic, I'm embarrassed. I can't remember what I'm doing. Enlighten me, educate me.
Okay, so the first thing is don't panic. That's the main message.
Excellent.
Because actually, functional lung nets associated with typical and atypical carcinoids are actually very rare. So certainly less than 7% or so, I think, is the quoted figure that actually have a functional syndrome related to the neuroendocrine tumor. So those
is that
yeah.
all carcinoids, or is that what about pulmonary? Yeah. How many?
No. So that's specifically for lung
rare,
carcinoids.
Yeah. Oh, for
that's
lung.
Specifically
Okay.
for lung carcinoids. Yeah. So the two which are probably the most common are carcinoid syndrome, which is obviously related to hormonal hypersecretion due to things like serotonin, and often is associated with large volume liver metastases, and you get the classic carcinoid syndrome of diarrhea, flushing, sometimes wheezing. The other common syndrome is Cushing's, which can be related to ectopic ACTH secretion. So I think if you've got, they're usually pretty obvious clinically. So, sometimes I get queries about somebody who's had a lung net who has got a bit of diarrhea. That's very, very unlikely to be related to a functional net syndrome. Whereas, so they're usually pretty obvious clinically in terms of, as I said, real obvious carcinoid syndrome or Cushing syndrome. So I think if you have a patient who has, clinical evidence of one of those types of syndromes, then yes, Tom, your urine 5-HIA should be done. Clearly, if it's somebody who you might suspect to have Cushing's, then you need to do their serum cortisol, their ACTH, and then get on the phone to your local friendly endocrinologist who can help you to manage that.
You'd be doing that in the presence of symptoms as opposed to routinely doing it on everyone?
Correct. Yeah, absolutely.
Chromogranin A is a...
Oh, yes.
Yeah,
serum.
so chromogranin A is a serum biomarker that is used in NETs, but the actual utility of it is pretty limited. I think if you've got diagnostic uncertainty around a potential NET, it can help. But in terms of routine monitoring and so on, it's personally, I think it's a relatively limited value.
Okay.
Yeah, as I said, I think for diagnostic purposes, it can sometimes be helpful. But in terms of reliability of it as a kind of tumor marker, in the same way that we use, PSA for prostate cancer or CA125 like ovarian cancer is really not, it's not as reliable.
And if you've got a functional versus a non-functional NET, apart from the fact they may have, as you say, carcinoid syndrome, apart from symptoms, does it tell you anything about the biology of the cancer, and does it fundamentally change your treatment options?
So I think patients with significant hormonal secretion, there's some evidence to suggest that, for example, the Cushing's group do worse. And it potentially can impact on your treatment options. Maybe we'll come on to that a little bit later, but so it is important for you, and it is really important for you to be able to diagnose it when it's there, even though it's relatively uncommon. And
so the message is look for symptoms first and investigate accordingly, as opposed to send off very complicated tests which you don't understand.
Correct.
In everyone who you come across.
That's the main message. And obviously from a patient perspective, these types of syndrome can be incredibly debilitating and really impact on quality of life. So it is important that you diagnose it when it is there.
And I'm going to ask what probably seems like a really basic question. So with those types of symptoms, would the patients always have metastasis, or can they get that type of syndrome just if they have an isolated lesion? Yeah.
So isolated lesions tend to be more associated with, for example, the Cushing's ectopic ACTH secretion. So that's a kind of common presentation. But in terms of full-blown carcinoid syndrome, then it's usually associated with presence of significant large volume, liver metastases.
Yeah, and I'm so glad you asked that, because I was thinking exactly the same question. I'm really glad you asked it for me.
So just for the simple respiratory physicians, if we get someone in clinic who's got that full-blown carcinoid syndrome, then we need to make sure we're checking their liver, and that's where we start getting worried. Yeah.
Yeah.
Okay.
Exactly. Yeah.
Okay.
Yeah.
So then we've talked about functioning versus non-functioning and kind of blood and urine tests. What about imaging? So the thing we always seem to get really het up in MDT is about which type of PET scan we should be doing, and should be doing both of them. Should they all have an FTG and a dotatate, and what is the role of a dotatate, and when should we go for it? It always seems to cause an immense amount of arguments, and it's tricky in current kind of climates where patients do sometimes wait for PET scans, hopefully not too long, but if you're ordering a series of tests, then it can take longer.
Yeah. So I think in the context of somebody who's presenting with advanced disease, it's absolutely critical to get a gallium dotatate PET. So just the principle behind this is obviously that well-differentiated nets, such as lung carcinoids, have a overexpression of somatostatin receptors. So a gallium 68 dotatate PET is basically a radiopharmaceutical tracer which is used to measure somatostatin receptor density. And we know that the sensitivity and resolution is very high compared to historical imaging that we used to use for this type of neuroendocrine tumor with what were called octreotide scans, which used a kind of SPECT and usually a kind of indium octreotide label. So it's for optimal staging, it's absolutely critical. So the question around when you should consider an FDG PET, I think, is really also important. Obviously, we've talked about this kind of spectrum of neuroendocrine cancers, so it's important to kind of understand that those patients with most well-differentiated disease, such as the typical carcinoids, are likely to have the highest somatostatin receptor expression and therefore the most avidity on a gallium dotatate PET. And conversely, with an FDG PET, are likely to have the least amount of uptake. So obviously, if you go from a typical to an atypical, and again, talking about the spectrum and where the kind of Ki-67 is, you will often have patients perhaps at the lower end of a proliferation index or the less aggressive atypical carcinoids who have more uptake on a dotatate PET, might be dotatate positive versus FDG negative, whereas at the other end, the kind of scenario that Tom mentioned of a much higher Ki-67, getting more towards the kind of large cell end of the spectrum, who potentially will have very little, if any, dotatate avidity, but will have very high FDG PET expression. And that's really important from a prognostic perspective, and it's really important from a therapeutic perspective. So certainly, I would always consider, an FDG PET absolutely for patients with an atypical carcinoid as well. Just because, as I said, it really adds extra value to the dotatate PET in terms of that prognostication and how you potentially manage that patient.
And I guess the thing from our point of view, as the people are kind of working the patients up, is that we always feel that these investigations obviously are best done before they have a resection, because you don't know afterwards if it was dotatate avid or not.
Yeah.
So and my understanding is that that's the best way, obviously, to try and get the imaging in first. So then post-op, we know which of our scans will be the most useful.
Yeah, absolutely. So I think if you've made a diagnosis preoperatively of a carcinoid through histology, and the patient is going for an operation, then absolutely they should definitely have a dotatate PET to understand what their somatostatin receptor expression is preoperatively, because that can sometimes help in terms of follow up post-operatively, although the kind of guidelines around how you should do surveillance, including functional imaging, is quite controversial, and there's no real consensus on that. So,
we've got another exciting podcast coming where we're going to talk about early stage neuroendocrine tumors. So we're not going to spoil the show, because that would be terrible.
No, it's kind of a thorny subject too. So, it kind of sounds like they all need dotatates, because if you think it's going to be a typical, then we expect that to have quite high uptake. But you're also saying if there's clear potential metastatic disease as well, then they should be having a dotatate.
Unequivocally, yes. It's because of the treatment options, which I think we're going to come on to. So things like somatostatin analogs that are effective treatments that we give for routinely for other types of neuroendocrine tumors, such as GI neuroendocrine tumors, that have relatively good side effect profile and so on. And so, it's one of the systemic therapies that we have in our kind of therapeutic
which is
armamentarium.
a perfect segue into the next question.
Perfect.
Thank you, Deb. That's marvelous. So let's move on to, because we're focusing mainly on advanced disease. So advanced neuroendocrine tumors, and just to say to the audience, we are deliberately ignoring small cell and large cell neuroendocrine tumors because that's such a massive separate subject. So advanced disease, which are positive on dotatate, let's say, what are the treatment options and how does that vary according to how positive the dotatate is? And I guess in advanced, we're talking here widely metastatic and there are no radical surgical options available. So the systemic treatments.
So I think, like any other patient with advanced cancer that you see, obviously you have to assess what the performance status of the patient is, what the fitness is, what the comorbidities, explore what the wishes of the patient and their family is. But I think that if you take, as you say, somebody who has a metastatic, say, typical carcinoid with quite extensive disease, which might be, for example, liver and bone, usually we would recommend that they commence some type of systemic therapy. For patients who are, who have relatively, let's say, low volume metastatic disease or relatively asymptomatic and are perhaps more on the typical end of the spectrum, a somatostatin analog is a completely reasonable first choice. So the data around somatostatin analogs for lung nets is, as with everything in lung nets, is pretty minimal. There was a trial called the SPINET trial, which actually had to stop recruitment early just because it had real difficulties in terms of recruiting. But in essence, what that study was a randomized double blinded phase 3 trial for patients with atypical or typical advanced lung nets, and they were randomized to either lanreotide.
Sorry, and these are all positive on dotatate, or is it
all
just
positive
regardless?
on dotatate?
Okay.
All positive on dotatate.
Any positivity?
Any positivity on the dotatate.
Okay.
And those patients were randomized to either lanreotide or placebo. Primary endpoint was median progression-free survival. Progression-free survival in the lanreotide arm was about 16, 17 months. In the placebo arm, it was 13 months. But the data for the typical seems to be better, as you would anticipate, because they're a better prognostic group. So the median PFS in that group was about 22 months versus about 14 months in the atypical group. So given that data, that's pretty, in terms of pretty suitable for many patients with first-line therapy to consider a somatostatin analog. You've then got consideration around molecularly targeted therapy, and the only kind of level 1 evidence that we actually have is for the use of everolimus, which is the mTOR inhibitor. So there was a trial called Radiant-4, which again was a randomized placebo-controlled trial for patients with either typical or atypical advanced lung carcinoid. Some of those patients had a prior somatostatin analog. Some had prior chemotherapy, which we'll come on to in a second. But the overall, the median progression-free survival in the everolimus cohort was about 9 months versus 3 months in the placebo. So in some patients who have, for example, more advanced disease, higher bulk of disease, perhaps an atypical histology, you might commence a somatostatin analog as well as everolimus at the same time. So in some patients, as I said, you might sequence it. So you give the somatostatin analog first, and then at a point of progression, then consider everolimus. I mentioned about chemo. So, chemotherapy for lung nets, again, real lack of evidence, mainly retrospective series.
Yep.
A whole range of different regimens have been looked at.
Lots of old school drugs.
Lots of old school drugs. So, platinum etoposide, obviously based on small cell data.
Yep.
Net physicians who treat mainly GI nets, we tend to prefer giving temozolomide plus or minus capecitabine There's some data for use of oxaliplatin-based regimens as a second line, but all of these are kind of associated with response rates of about 15 to 25%,
Okay, it's quite low, isn't it?
survival of 6 to 12 months. The ESMO, European Society of Medical Oncology guidelines, actually recommend temozolomide-based regimen as your first regimen, primarily just for convenience, because it's oral and because of perhaps less toxicity than the intravenous platinum-based regimens. So we tend to reserve the chemotherapy regimens for those patients who present with very extensive metastatic disease, often symptomatic, who don't have significant expression of somatostatin receptors on the dotatate PET, and where you need to try and get a response perhaps quicker, because chances of response in terms of significant shrinkage with everolimus or lanreotide is relatively small, probably under 10%.
And what about PRRT? He said, not knowing what he's talking about. I've heard it mentioned a few times. My clinical oncology colleagues, much more expert than me. Do you use it? When do you use it? What is it?
Okay, so PRRT, or peptide receptor radionuclide therapy. So the kind of main treatment that we use is lutetium-177, which in essence is just a radiolabeled somatostatin analog. So again, referring to my kind of GI net practice, there was a trial which was performed called the NETA-1 trial, which was done in patients with small bowel nets, advanced small bowel nets, where lutetium was compared to patients with given high dose somatostatin analogs, and it really was a very positive study with an improvement in median progression-free survival of over 2 years compared to somatostatin analogs. Again, we don't have the same level of data for lung, and having said that, again, there's been small series which have shown that the data looks promising. Probably, you're talking about median progression-free survival of 18 to 24 months, response rates probably about 15 to 20%. The problem that we have is that because of the lack of evidence compared to the GI nets, it's not routinely funded. So, for example, in the UK, there is no routine funding through the Cancer Drugs Fund for lung nets who you're considering for PRRT. Having said that, there are certain centres that are able to access it through special programs, including at Guy's. So I think it's always worth considering and exploring it in patients who have progressed on, somatostatin analog, everolimus, perhaps chemo as a potential option.
Got you.
And so just breaking that down slightly more simply for the simple respiratory physicians. So for the non-functioning neuroendocrine spectrum, are those guys going kind of straight to chemo? Is there any other options for them?
So what I've talked about is both the kind of non-functioning and the functioning, really. I mean, the only differences in terms of functional nets, really, i.e. those patients who have significant carcinoid syndrome, is really those patients need potentially other things considered, such as if they have large volume liver metastases, we might consider embolizing the liver metastases. That often can reduce carcinoid syndrome. You need to screen them for things like carcinoid heart disease, which often can happen in patients with significant syndrome. But broadly speaking, in terms of how you manage them from an advanced disease perspective, as I said, if the dotatate PET is positive, then go down the route of a somatostatin analog. As I said, in some patients, you might give everolimus alongside the somatostatin analog. Chemotherapy, we tend to reserve for patients who have progressed on a somatostatin analog or everolimus, or in patients who are very symptomatic at the outset and have good performance status.
So we're coming to the end of our allocated time. So I'm just going to ask a couple of more questions. Medical oncologists, we absolutely love molecular profiling. It's the high point of our day. Should I be molecular targeted profiling my patients? I remember you and I Debs was walking down the street in Paris at ESMO recently. You told me about a patient of yours with I think had an ALK fusion. Made me realize maybe I should be profiling these guys.
Yeah, so I wish I could give you a better tale of which is similar to what you see in non-small cell lung cancer. But the problem that we have for well-differentiated neuroendocrine tumors, be it lung or gastrointestinal tract, is that unfortunately there's a lack of real actionable driver mutations or fusions. There are case reports of ALK rearrangements, and I mentioned to you, a particular patient of mine who we've been able to get onto ALK therapy because of a rearrangement. But I think they're relatively rare and uncommon. I mean, I think that it's reasonable once you've got a patient with advanced disease to test them for NTRK, which is obviously routinely available. NTRK testing is routinely available through your GLH, and that would always pick up something like an ALK rearrangement just in case. So I think, yeah, they're rare, but I think it's important that we identify them, because of the potential therapeutic options available.
And it's probably a little bit tricky. We already talked about the different lines of treatment. Prognosis-wise for patients, I'm sure there isn't a simple answer really. Does it help based on the typical versus atypical, or are we more looking at kind of how extensive their disease is really?
Yeah, so definitely atypicals have a much worse prognosis. So you're talking about, for patients with, say stage 4, typical carcinoids, 5-year overall survival is probably in the region of about 60%, whereas for patients with atypical carcinoids, it's probably in the region of about 20 to 30%. So the atypical group absolutely has unfortunately a much worse prognosis. Obviously, patients at the other end, who obviously are able to have a curative lung resection, the kind of 10-year disease specific survival for a lung carcinoid is over 90%. But even for stage 1 disease, again, for atypicals, it tends to drop off a bit, perhaps to about 80%. So you can obviously the kind of classification system that we have for lung carcinoids, you can clearly see the difference between the typical and atypical across all stages 1 to 4.
And as you said, those early stage patients, we're having a different podcast about that, and obviously they have quite a good prognosis. But in your experience, is there a higher risk of recurrence for the earlier stage patients between the different subtypes?
Yeah, so the atypical carcinoids again have a much higher risk of recurrence, and can often have quite late recurrence as well. So these patients often should be surveyed for long periods of time, even beyond what you would normally regard as normal for in terms of 5 to 10 year follow-up. Yeah, absolutely. I mean, the atypicals again, as I said, have much higher risk of recurrent disease, and should have a kind of slightly more intensive kind of follow-up program in terms of surveillance related to those, given that particular risk.
And the last question I think we're going to ask you is, when do we refer to you, Debs? Unless you don't want to have every single typical and atypical carcinoid that's been resected. In the metastatic setting, do you think that all patients with a metastatic carcinoid should be referred up to a specialist centre? And if not, which one should and which one shouldn't, broadly speaking?
Yeah, so I mean, I think obviously, clearly, there are some cases which are more straightforward. I think that the more complex cases, and perhaps we've discussed some of those, such as, for example, patients with complex functioning syndromes like carcinoid syndrome or Cushing's in the metastatic setting, certainly I think those patients should be referred to, your local NET center of excellence. I think that again, if you're unsure about whether a patient might be suitable for consideration of lutetium, even with kind of funding restraints and that we currently have, then again, I think those patients is always worth a discussion. And obviously, we don't have a huge number of trials for lung nets, but we should always think about what trials are potentially open and available, and so it's always worth speaking to your local net center in the kind of advanced disease setting to think about trials for suitable patients.
Debs, thank you very much. I think that wraps it up. It's just for me to say thank you very much, Debashis Sarker, for joining us for our first new format podcast. We're very grateful for your time. And with that, we'll call it a day. Thank you very much.
Thank you.
Thank you for listening. We hope you enjoyed this podcast. For more information on BTOG, including educational events and how to join, of course, you can visit www.btog.org. Just to remind you, we would love to hear your comments, thoughts, questions about things we discussed, and for the really interesting ones, we'll even discuss them in our next podcast. You can contact us on info@btog.org or on Twitter @btog.org. Thank you very much.